Although burns can be severe in nature, many minor, superficial, and superficial partial thickness burns will heal with little more than cooling and basic analgesia. In these cases, treatment in the community by paramedics or referral to an urgent and primary care center may be more appropriate than conveyance to the emergency department. Let's quickly review some basic skin anatomy. Our skin is the largest organ in our body, and laid out flat, it would cover close to 1.7 meters of ground. Between us and the rest of the world, it lies as an interface, making up 16% of our physical weight. Besides keeping our organs contained, it has many purposes. Made up of three primary layers, the outermost being the epidermis, which is further divided into sublayers and lays on top of the dermis. Below the dermis, there is the hypodermis, also known as subcutaneous fat, and the hypodermis is not really a true skin layer. Now, the epidermis is very thin, and interestingly, its only blood supply is at its base. The epidermis is what essentially protects the dermis, and its cells shed off every day. What happens here is that the cells at its base membrane receive blood supply from small capillaries in the dermal layer of the skin. And this allows the cells of the epidermis to receive nutrients and divide while moving upwards. As the cells divide and move up, they get less and less blood supply until they die. Some important structures that make up the skin anatomy itself are the hair follicles, which help with sensation and indirectly in heat regulation and lubrication. The main arteries and veins of the skin really supply the hypodermis and the dermis, while the smaller capillaries branch off and supply all the way to the base of the epidermis. There are many sensory nerve endings a part of the skin, which are important in sensory aspects, such as detecting pain, heat, and pressure. Finally, it's important to mention the glands. Our glands around the skin help in lubrication as well as releasing antimicrobial substances and heat regulation. It should be pointed out that we normally have what's called opportunistic organisms, for example, bacteria living on our skin. Damage to the skin, such as a cut, can introduce bacteria to this area, causing problems. Similarly, if a person suffers from a burn, it can introduce bacteria and other organisms, such as fungi, easily into the body, and it can cause significant problems. Why does knowing the layers of the skin help us to appreciate various types of burns? Burns are injuries to tissues caused by heat, friction, electricity, radiation, or chemicals. Inhalation burns are caused by small particles of smoke. Radiation burns include UV radiation from the sun, and cold exposure like frostbites are also considered burns. When you assess a burn, it's important to know the cause and the depth of the burn. Initially, we can divide these into superficial or deep. Keeping the layers of our skin in mind, we can understand what happens to the skin as a burn progresses deeper. So stay with me, and we'll dive into some pathophysiology and discuss the mechanism of disease. If it's a superficial burn, it will cause damage to the epidermis and the capillary level of the dermis only. Again, you have blood vessels here. These burns will damage the keratinocytes, which are the cells in the dermis, and will also activate an immune response with the immune cells around the area. The damaged keratinocytes and immune cells will secrete pro-inflammatory cytokines, triggering an immune response. The cytokines will stimulate nerve endings around the dermis. The sensory nerve endings here can be the ones that detect pain, for example, and pain is an important feature of superficial burns. Some cytokines will cause an increase in vascular permeability. The increase in vascular permeability will cause fluid to leak out and may lead to interstitial edema. As fluid leaks out, it can cause hypotension. This fluid can actually accumulate in one area, which is the cause of the blister on the skin surface. The sensitive blister can rupture and release fluid onto the damaged skin surface, thus resulting in the superficial burn having a moist appearance. The cytokines secreted by the cells above will also cause concurrent vasodilation, causing further hypotension in severe cases. Finally, vasodilation contributes to the warmth in the area, as well as causing blanching of the skin and erythema. The blanching skin is another important feature of superficial burns. These burns can be further divided into superficial epidermal burns and superficial partial thickness burns. In superficial epidermal burns, only the epidermis is involved, and most common cause here is your regular sunburn when you get a dry red skin, which is painful. On side note, superficial epidermal burns are not included in the assessment of the total body surface area burn calculation. In deeper burns, you have more than just damage to the epidermis and the upper part of the dermis. You've damaged all the way down, extending to the hypodermis and potentially to the layers of muscle, fascia, and bone beneath. Deep burns can thus cause severe damage to blood vessels in the skin. Because you have increased damage to the blood vessels, everything will leak out. You have no blood supply to the area, and you can eventually get this dry, non-blanching surface. It is this dry, inelastic, non-blanching symptom that is an important feature of deep burns. Further to this, deep burns extending to the lower layer of the dermis can destroy other structures and sensory nerve fibers. Initially, pain can be detected, but as the sensory nerve fibers are damaged, you get hypoesthesia, a reduction in sensation. Loss of sensation with minimal to no pain is another important feature of deep burns. Now, obviously, not all your blood vessels are damaged when these blood vessels are. The function of blood vessels will react to the cytokines produced around the area. The vessels will increase vascular permeability, which will cause fluid to shift out, causing interstitial edema. So the fluid shifts out into the intravascular space, into the interstitial, and this huge amount of fluid coming out of the vessels will result in hypotension progressing to circulatory shock. This hypotension, as a result of the shift of fluid, occurs far more often in deep burns rather than superficial. As mentioned before, many burns can be treated at home or referred to the UPCC. However, there are some burns which require transfer and referral to the burns unit because of the complications that may come with them. Now, these types of dangerous burns you can say include chemical burns, electrical burns, and inhalation, as inhalation burns, for example, can compromise airways and cause significant lung injury. But how about the burn depth? Well, we will continue to refer partial to full thickness burns. Also, consider transport of any superficial burn greater than 20% of the total body surface area. Burns referred to emergency include those to the very young and very old, paying particular attention to special areas such as the head, major joints, genitals, hands, and feet, along with pregnant patients. Reviewing our calculations for total body surface area, the rule of nines divides the body into sections of 9%. The entire head and neck, anterior and posterior of the chest each, anterior and posterior of the trunk each arm, and the legs anterior and posterior each, with the groin making up the remaining 1%. Another quick way to measure total body surface area is by using what's called a Palmer method, where the patient's palm and fingers will represent 1% total body surface area. Remember, it's the patient's palm and fingers and not your own. This method is useful for small scattered burns. Determining the patient's total body surface area helps determine an appropriate treatment plan, and transport may be considered for burns encompassing greater than 20% of the patient's body. Now that we've determined the patient has a reliable primary care follow-up and is capable of self-care, we are now going to ensure that we've provided 20 minutes of active cooling to any burn of any size, followed by an oral analgesia. We will contact Clinical to confirm our secondary triage criteria using the Manchester triage system. If the patient has unresolved pain or inconsistent follow-up with their own physician, conveyance to a UPCC or emergency department is most appropriate to ensure timely follow-up. Thank you for your time today. If you have any questions, you can contact clinical practice at bchs.ca or reach out to your local practice educator.